It is my pleasure to welcome the members of today's panel on COVID-19. Dr. Donald Murphey, pediatric infectious disease specialist and chair of TMA's Council on Science and Public Health, is our moderator today. He is joined by Dr. John Hellerstedt, Commissioner of the Department of State Health Services and the Governor's top medical advisor. Dr. Hellerstedt has been the visible, steady public voice of medicine since the coronavirus came to Texas. Through his ability to blend fatherly reassurances with frank warnings, as one newspaper put it, he has elevated the overall COVID-19 discourse through wisdom and pragmatism. And by including TMA in many discussions and making himself easily available to us, he has instilled confidence in our frontline physicians. Also joining the discussion today is Dr. Jennifer Shuford, Chief State Epidemiologist at the Department of State Health Services, a member of the State Expert Vaccine Allocation Panel, and consultant to TMA's Committee on Infectious Disease. In countless calls and meetings, Dr. Schufer has supplied the latest COVID-19 statistics, research, and guidelines that stakeholders and physicians needed to make good decisions. Please join me this morning in giving a warm welcome to our panelists. Dr. Murphey, take it away.
Thank you, Dr. Villarreal. I wanted to start by saying thank you to all of the Department of State Health Services staff, and specifically Dr. Hellerstedt and Dr. Shuford. These have been tough times, going on for 2 years now. We have needed good leadership. I'm thankful that the Health Department has had some better funding and better leadership. I'm happy that we've been able to work together. All of the physicians in Texas appreciate what you guys have been doing. We know it has not been easy. I was at the Capitol speaking on an issue and was with Troy Alexander and heard him comment that, TMA was one of the voices, kind of the few voices that was really speaking up and supporting good public health in Texas. So we have your back. We love you. We appreciate you. You guys have been helping us with the Educate TMA staff and leadership. You've been working with the Council on Science and Public Health. You've been working with our COVID task group that has been working very hard. Thank you, Wendy. You've been working with the Texas Public Health Coalition. You've been doing bi-weekly calls with leadership. You've been spreading information that's good information and helping TMA with messaging. We appreciate all that. We've all been very busy. These have been kind of confusing times. There's constantly changing information. There's constantly news on COVID, and it's been challenging. And I think together we have been doing our best to protect the health of Texans. And thank you all. Jennifer, you want to start in with some background information?
Sure, thanks. So I'm going to start off by just kind of setting the scene, telling you, giving you some of the more recent epidemiology of COVID-19 across the state of Texas, and showing you a little bit about what we're doing with vaccines and therapeutics. And I'm going to hand it off to Dr. Hellerstedt, and he can get into some of where our agency is going, some of the decisions that we're making. So, but let me start off by just setting the scene. So next slide, please. Next slide. Thank you. So this is just a statewide overview of new cases reported to us per day. So these are confirmed cases, and you can see that this spans the whole pandemic. And that blue line that you see there is a 7-day rolling average of newly reported cases by day. And so you can see these 4 big surges of cases that were reported to us, representing these different pandemic waves going through Texas. And that this most recent wave that you see all the way on the right hand of your screen just dwarfs the other surges that we had by case counts anyway, we were getting 2 to 3 times as many case counts during the peak of this most recent surge than we were in the prior ones. And so it's been a really amazing the way the transmissibility of Omicron and the way it's spreading through the state rapidly. Next slide, please. Now, this is a display of the total people in the hospital with COVID-19 by day for the whole pandemic. You can see how each one of these surges here just kind of mirrored what we saw with the cases. What you see is, and so that blue line is the 7-day rolling average. You can see that for the last 2 surges, right before this Omicron surge, that we were getting at our peak about 13 to 14,000 people in the hospital. You can see that that's about exactly where we're at right now with our Omicron surge as well. And so even though we're having 2 to 3 times as many cases reported to us today, our hospitalizations are topping out at about the same place that we saw over the last 2 waves, which is incredibly straining on our healthcare system, but we're just glad that the severity of illness wasn't greater and didn't put more strain on our hospitals. Right now in Texas, statewide, we're seeing a flattening of the hospitalization curve and starting to see some decreased numbers of patients in hospitals. You saw that on the case curve that I just showed you a moment ago, that the cases statewide are starting to come down for this most recent surge, and that's really encouraging. It's not the same all across the state, though. We know that, you know, Omicron really hit the Houston area and started spreading there a little bit earlier than we saw in some other communities in Texas. And so likewise, they're coming off of their curve a little bit sooner than some other communities are. We know that some other communities, they're still having increases in case counts. And that's exactly what we're seeing in hospitalizations as well, that in the Houston area and the Dallas-Fort Worth area, we're starting to see decreases in the number of hospitalizations. And so overall, we're starting to see a flattening of hospitalizations across Texas, but that there's still some communities where we're seeing increases. Next slide, please. And this is fatalities per day that are reported to DSHS over the course of the pandemic. You can see how those 3 large surges just mirror what we saw with cases and hospitalizations. And if you look at the far right, you can see that we're just now on the upswing, kind of in that exponential phase of the reporting of fatalities to us for this Omicron surge. We're getting a lot of reports of deaths right now, over 200 per day. And so we expect to continue to see fatalities rise due to the Omicron surge, since it lags behind cases and hospitalizations. And then the death reporting even lags a little bit behind that. So we will continue to see increases for a little while before we see decreases in reported fatalities for Omicron. Next slide, please. I just wanted to give you a quick update on our website too. We just recently did a redesign of some of our COVID-19 pages, where now we've got better breakdown of case data and fatality data showing demographic and age group breakdown. And so hopefully this will be helpful to you. Previously, we were only posting the demographic information on ones that we had complete case reporting on. So it was a really limited number. Now we're using the electronic lab feed. And so there's a lot more of our cases represented there. They're broken down by 2020, 2021, and we're going to load the 2022 demographic data for cases and deaths soon as well. And so be looking for that. That might be helpful for you in your practice. All right, next slide, please. This is also up on our website. This is variant proportions. And so this is a week by week breakdown of the proportion of sequenced samples that show different variants. And so the orange ones were Delta, and Delta really predominated the scene for a long time in Texas. It was so transmissible. But what you can see in the purple line is that starting the week that ended December 4th, we just started to see Omicron here in Texas. And within just a couple of weeks, 2 weeks later, it was already making up more than 50% of our sequenced cases here. And now it's reached 99%. And that was as of a week or 2 ago. And so nationally, we think that is about 99.5% or even higher. So Omicron, you can see how it just took over the landscape, partly because of its transmissibility, as well as its ability to evade previously established immunity. Next slide, please. Next slide, please. But what we know is that vaccines have been really important in protecting our population through the whole course of the pandemic. This is a breakdown of age groups, the proportion of different age groups that are fully vaccinated over time. And so you can see down at the very bottom of the screen, that blue line is the 0 to 4-year-olds. And so they're still not eligible. And so they're still at 0%. That orange line, which is the lowest one showing any measurement at 15%, that's the percentage of our 5 to 11-year-olds who are fully vaccinated, meaning they got that whole series, that 2-dose series of the Pfizer vaccine. Then you can see each of the other age groups. And so our 12 to 15-year-olds are above 50% fully vaccinated, which is great. If you look all the way at the top, that's our 65 to 74-year-olds, and they're at about 86% fully vaccinated, which is fantastic. There's, Texas isn't at the forefront of that. There's some other states that have a higher percentage of their elderly who are fully vaccinated. And so we still have a little ways to go there, but for over a course of a year, we've done a lot. And that is in large part to y'all taking the opportunities to talk to your patients about getting fully vaccinated. So thank you so much. Next slide, please. But what we know about Omicron and the new data coming in is that booster dose is really important for this variant and providing protection. And so new data is showing us that booster dose can provide protection against getting infected with Omicron, getting any sort of symptomatic disease, going to the emergency department, being hospitalized, or dying from Omicron. And so that booster dose is super important. And as we look at our age groups, we can see that that the booster doses are differentially accepted in these different age groups. So you can see that 12 to 17-year-olds, of those who are eligible for a booster, only about 10% have received their booster. For the 18 to 64-year-olds, about 30% of the eligible population has received their booster dose. And then for the over 65s, about 60%. So that's great. We've got about 60% of them boosted. But it would be really important with Omicron, as well as potentially future variants, for them to be boosted and have that extra level of protection. Next slide, please. I did want to just quickly show you that this is part of our website now. This is cases and deaths by vaccination status. And what we have done is matched all of our electronic case reporting data to our immunization registry. And then we've also taken death records and matched them to our immunization registry so that we can show the rate of cases and deaths for unvaccinated and fully vaccinated for points in time. And that can be broken down by age group. This is a Tableau dashboard that's on our dashboard now, on our website now. And you can see that you can break it down by age group and either cases or deaths, and really see how much protection being fully vaccinated is offering people through the course of the pandemic. We're also going to introduce booster doses up here to show the additional protection that booster doses give. And we're planning to add that in the next 2 to 4 weeks. Next slide, please. And one more. And so this is looking at therapeutics. The federal government has tasked state health departments across the nation to help allocate therapeutics, while the therapeutics have a greater demand than supply. And so we've been involved in allocation of, it was mostly those monoclonal antibodies for outpatient use, including sotrovimab, bamlanivimab, etesevimab, which is that Eli Lilly combination product, and then the Regeneron combination product, REGEN-COV. And so we were kind of busy doing that. And then when Omicron came along, it was resistant to the REGEN-COV and the bamlanivimab, etesevimab combination, leaving sotrovimab. In the meantime, though, there was the introduction of the oral antiviral medications, molnupiravir and Paxlovid, as well as Evusheld, that longer-lasting pre-exposure prophylaxis. So those are ones that we're currently working on. Dr. Hellerstedt can talk more about that, but I did want to show you the map of the regional infusion centers that are state supported and are meant to provide regional access for therapeutics across the state, and primarily with sotrovimab right now, but hopefully in the future with new therapeutics coming on the scene and new variants, we might be able to hopefully add some therapies to that. So next slide, please. that's where I'm going to end, and I'm going to pass it off to Dr. Hellerstedt for some more in-depth, stimulating conversation.
Very good. Thank you, Dr. Shuford, and thank you, Dr. Murphy and Dr. Villarreal, for your kind words. We are all in this together. I had 20 years of the providing clinical care in pediatrics. And so I know how much harder it is for people on the front lines to not only be working very hard hours, missing aspects of their life that would have given them rest and pleasure, and then having to face loss and suffering in their patients as time goes on. So thank you all very much. We're very humbled. I will say my team is amazing. My team has worked, 7 days a week throughout most of the pandemic. Even now, some of the things that we have had to do are settling down, in the sense that, for instance, what Dr. Schufer referred to along the distribution of the therapeutics, that's a major heavy lift for us. It involves a lot of review of data. It involves a lot of hours. It involves being able to be integrated into new and rather complicated and not necessarily all that functional IT systems that are foreign to us and all that sort of thing. So I would like to say to the medical profession, all healthcare workers, and to my own staff, my theme is we need to lift each other up. And by that, I mean, we really understand what we're doing and what we've gone through. And I take to heart, especially Dr. Villarreal's comment about how much of a toll it takes on us. I've really only come to realize how stressful this has been for everyone by looking in the mirror. I would want folks to, again, lift each other up. That's where we find our strength. This too shall pass, but that's my segue into, okay, well, what's going to happen next? I think I'll make Dr. Hotez happy by saying that I can kind of sum up my whole message in 4 words: booster, 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 booster. I think that's especially important because, again, we'll come out with that other data to show how effective it is. The thing that's disappointing about Omicron is that it seems to be really better at reinfection and breakthrough infection than any previous variant has been, to the degree to which that it really kind of makes a difference. Everybody knows people who have been quote unquote fully vaccinated, which is a bad nomenclature, which unfortunately the CDC cannot change. And even people who have been boosted or up to date, as the new preferred nomenclature for that, and have nonetheless gotten COVID. Now, typically it's milder and it saves them from the hospital and from the grave. But at the same time, part of this has led into a narrative in the public's mind. That's a dog, by the way, in the background, in case you hear it. Hang on, I got to do something about that.
Thank you, Dr. Hellerstedt, getting that dog. When he was done, I was going to say a few things about pediatric COVID. I think I'll take this opportunity to just start on that, and then as soon as he's available, he can pick back up. Pediatric world has been impacted by COVID, not as hard as adult care. We really want to have a shout out to all of the adult ICU, ER, pulmonary, critical care, hospitalists. They have been overwhelmed. We have not been quite so overwhelmed, but we have been working hard in the pediatric world, especially inpatient. You back, John?
Well, yeah, I'm not sure I can completely control them, but back to where I was. Omicron is a very tricky opponent, and as I was saying, there seems to be a narrative out there in the public that is false, and that is, well, why get a booster? Why get vaccinated? Because you're going to go ahead and get COVID anyway. Yes, the strongest protection protects you from hospital and from death, But it's absolutely true that being boosted will actually help protect you from being infected as well. And it's that infection piece, we know that the people who are infected are contagious. And what we want to do is decrease the number of contagious people in our state to the absolute minimum, because I can't really envision, I'm not confident that I have a vision of what the level of disease burden looks like after the peak of COVID, of Omicron. Is the dog interfering with me? Okay, I'll let them live. That's kind of where we are. I mean, I think Dr. Shuford covered all of the basic trends in science, and I'm sure this audience is pretty sophisticated and aware of what's going on. But again, my plea would be that we need to be asking our patients, stressing to our leaders the value of the booster, because not only does it have an intrinsic properties that I talked about, but when you compare it to other things that might help stem the tide of COVID, it's the one thing, the boosters and the vaccines are the one thing that we have plenty of that is widely distributed and pre-positioned, if you will, all over the state. It's readily accessible and it's free. And you can't say that about any of the other monoclonal antibodies or the oral antivirals or any of that sort of thing. That's one of the reasons to recommend it. The other part about booster is that these are not the vaccine resistant people. This is not the people who will never get vaccinated. This is people who've had their vaccines. And Dr. Schuford's latest data, I mean, if I did my math right, there's about 10 million people in the state of Texas who are eligible, but have not yet received their booster. That's an awful lot of people who I think really just need to get the message of what the advantages are to them as an individual and to us in particular as a society. I mean, people are sick of this pandemic. They really want to get it behind us. And the only way that I can think of that gives us the very best chance of doing that is booster, booster, booster. So I'll stop there.
Thank you, Dr. Hellerstedt. So pediatric COVID, we have had kind of full children's hospital, busy ICUs with each wave of COVID. I think Delta last summer was worse, and it really hung on for a while. We really weren't over it in my mind when Omicron came. So I think people have questions about immunizations now that we have mRNA vaccines licensed down to 5 years old. You know, do those kids really need vaccine? You know, do they get sick enough? And the answer is yes, they do. The rates are much higher than you see with influenza that we do recommend vaccine routinely for. There's kids in the ICU. There's kids who have died with COVID. There's kids who are immune compromised, kids on treatment for cancer that have had COVID and have had a very difficult time and are still trying to get over that. The other thing that we have in pediatrics is MIS-C, multisystem inflammatory syndrome in children. And that is a couple weeks after acute COVID infection, fever, signs of Kawasaki disease, signs of very acute, very severe myocarditis. And it is reportable. We're reporting cases, but it's kind of a difficult diagnostic disease. It's pleomorphic. It's hard to pin down. So I did a little straw poll. I think we have now had probably about 1,000 cases of MIS-C in Texas, and a fair number of those kids were in the ICU. Fair number of those kids were younger. So if you think about COVID vaccine, for kids, it's important. Kids are hospitalized, kids can get MIS-C, kids can end up in the ICU. So I think we should be speaking out for the need to immunize kids. If you look at kids in general, they get COVID at the same rates as adults, and they spread COVID really at the same rates as adults. So we shouldn't think of them, even though they usually have mild disease, as not a part of the epidemic and pandemic. We need to immunize them, as Dr. Hellerstedt said, to get this under control and to move on. Just like flu, if we immunize against flu, we know that adults benefit in the community. So I think we need to get herd immunity and protect those kids as soon as we can. So the rates of immunizations in 5 to 12-year-olds is about 15% right now, and we need to get that way up. We're going to have immunization for kids 2 to 5 years old, probably late spring. Their dose is lower. They did not respond as well to 2 doses. There's a 3-dose series that's getting studied right now. Some of that's happening here in Texas. And then for the kids 12 and up, the rates of booster immunizations are fairly low. So we need to work on that as well. I think for me, with COVID in general, at the beginning, people were saying this is unprecedented. I heard on the news over and over, this is unprecedented. And I kept thinking, this is not unprecedented. We've been talking about this for a long time, avian flu and SARS and Ebola. And we had been saying we need good public health, we need good reporting, we need good tracking. And so hopefully now people will appreciate how important that is. I think we're going to be dealing with COVID in the future kind of as a normal respiratory viral illness along with flu and RSV and other things. And we're going to need to be able to track those and see how bad are they, when are they coming, what strain is it? And we need great reporting, and we need great health department lab and information exchange. And then we're going to need to respond to that and say, what do we do when we see this evolving? Can we mitigate? Can we wear masks? I think we're going to have to get used to some of that, and also probably work on improving air quality indoors. But looking down the road, we need to fund public health better than we have, and we need to keep funding it longer than we have before. One other thing that has bugged me over the last year or so is that there's a beating up on vaccines that is really short-sighted. Those of us who have been around through the growth of more and more improved vaccines, we've seen our kids be healthier. We've seen the benefits for the whole community. So I think we should be speaking up for what we know is true, which is vaccines are one of the 10 best things we've ever done for public health, and they protect our kids, they protect us. And so yeah, speak up for vaccines, speak up for public health, and go get those boosters. That's all I have to say. We're going to shift over to some questions.
Wonderful. Thank you so much to all of our panelists. Our first question comes from Dr. Berger, and it's really a question about the data. Are the first 2 weeks after injection counted as vaccinated or not?
I can.
Dr. Schufer?
That. Yeah, so no, fully vaccinated is at least 14 days after you've completed the whole series. And so for the mRNA vaccines like Pfizer and Moderna, that's 2 weeks after your second dose. And for the Johnson & Johnson vaccine, that's 2 weeks after the single dose.
Wonderful. Thank you so much. Our next question is from Dr. Robert Byrne. Is there evidence that a 4th or greater booster will be recommended ultimately?
I was on a call yesterday with the director of the CDC, and I think it's fair to say none of us should be surprised if that happens. There isn't the data to support that yet, but of course there can't be, because the only way to gain that data is for time to go on and for studies to show what happens to immunity over time. And so if I had to bet, I would be willing to bet that there will be multiple boosters, and until, again, there's some kind of alteration, if you will, in the fundamental aspects of the virus itself, it truly becomes mild, for example, and not the milder that it is now, although it's still deadly, as we know. So I would say there's no date certain, but I would be surprised if there wasn't a need for extra boosters.
Oh, wonderful. Thank you so much. Our next question is from Dr. Elizabeth Torres. Have there been any significant trends regarding side effects of any of the vaccines? We still have patients who remain skeptical about vaccine safety.
I'll let Dr. Shuford start in where I leave off. I would just say that that's a really important thing. There are people out there who go look at the vaccine adverse reporting system accounts, and they will make the claim that there's thousands of deaths due to the vaccine. Well, as we know, that their system was intended to be all inclusive, to capture as much information as possible. So anybody, doesn't have to be a physician, can enter if they suspect that there's an adverse reaction to a vaccine. The CDC, I believe, is the one who looks at that data, and they try and do an analysis to see if there's trends, and they will dig down and do a little deeper case investigation. But I'll ask Dr. Schufer to comment if there's any patterns that have emerged.
So I'm sure y'all already know all about this, but for the mRNA vaccines, one of the biggest adverse events that is concerning is the myocarditis, pericarditis that's been associated with it, especially it's shortly after the second dose often. Thankfully, that has not shown to be increased after a booster dose. And so even for those age groups of the 12 to 17 or the 18 to 29-year-olds, that we're not seeing more after a booster dose. And the thing to consider too there is that there is more myocarditis that happens with actual COVID infection than there is with these vaccines. And so we continue to recommend those vaccines. And then for the Johnson & Johnson vaccine, the big one was that TTS, the thrombosis with thrombocytopenia syndrome, which did result in some deaths. It was few, but it was enough that considering that there's other alternatives, there's mRNA vaccines that are highly effective and that most people can take. The CDC did put the recommendation then that they prefer, ACIP and then CDC, that they prefer the mRNA vaccines over the Johnson & Johnson vaccine. Aside from those really big adverse events that have been talked about in the media, and that CDC has done some nice risk-benefit calculations on, there haven't been a lot that have come to light that have been statistically significant in the vaccinated group. It's just there's a lot of the just kind of mild to moderate side effects that people have after the vaccines that everybody is plagued with, but that resolve quickly and are relatively mild in the end.
I'd like to reinforce what Dr. Schufer just said. If you think about myocarditis, a lot of that was teenagers and young adults. And we saw a couple teenagers with mild myocarditis post-second dose of mRNA vaccine, and they get better with a little bit of non-steroidal and some observation. Their length of stay is usually a day or two versus probably 1,000 cases of MISC in Texas. And those kids have severe myocardial dysfunction, and they may have prolonged myocardial dysfunction. They're in the ICU on pressors, and they may have arrhythmias. So it's really night and day. Immunization will prevent MISC that's severe, and the myocarditis that's associated with COVID vaccine is rare, and it's mild, and it's transient.
Thank you so much. Our next question is from Dr. Emick. Has the health department been tracking long COVID and the long-term effects of pulmonary damage from the more severe cases of patients who survived to be discharged?
Dr. Schubert?
Yeah, so we have not been. We have, the required reportable parts of COVID-19 are the infection, so positive, negative tests, and we're asking for reports of MISC as well. And so we're getting all of that information, but not as much on the clinical complications. And part of the reason is that, early studies showed 5 to 85% of people were having long-term symptoms from COVID-19. So we expect that a lot of the population is. However, we are interested in that. And so we have been working with UT School of Public Health and are interested in, we're going to apply for a grant to do better surveillance on these longer term complications of COVID-19. NIH and CDC are working together to really do better surveillance of that nationwide. And we're applying to do that better for our Texas population. So we'll see where that comes. In the meantime, a lot of that just not really surveillance, but evaluation of those longer term complications or symptoms from COVID-19 are happening in the clinical setting and not being reported to public health.
That's good news to hear. We have a lot of questions coming into the chat, so we're going to do our very best to get to as many as we can. Our next question is from Dr. Veronica Vasquez. Any projected timeline on when vaccines will be available for children under 5 years old?
I can speak to that. We don't know a definite time. Those studies are enrolling and going on, and some of that's happening here in Texas. And I think it's at least a couple months away. It may be several months away. I am hoping late spring that that the current studies will be successful and that we'll hear about that.
Thank you. We have a question from Dr. Bailey, who called the Fort Worth RIC this week and was told they have no MABs and weren't making appointments. Is there, and what is the projection for MAB availability?
I'll start on that, and Dr. Schufer can, I think, take it up. All along, there was more demand really for MABs than there was supply. However, that got considerably worse with the emergence of Omicron, where the only monoclonal antibody that's useful for treatment is the sotrovimab. And the requests, and I take them, as a function of the demand. So in other words, the request for sotrovimab courses or doses is 10 times the allotment that's given to Texas. And every time we get on and talk to the feds, for one thing, I made them say it in very direct terms. The limiting factor is the ability to manufacture it. I gather that they're looking at alternatives to see if there are other drug companies that could be manufacturing the sotrovimab. But in other words, they're not holding stuff in stockpiles or things like that. They're really giving everything out that they have. It's just that they have so very little. And so all of our, I think it would be true of pretty much any one of our regional infusion centers, that when they get it in, they schedule folks and they give it to the last drop, and then they run out, and for a period of time they're not able to treat anyone.
Yeah, I heard that that they're hoping that the manufacturing can really pick up during January, so that we've got better supplies in February and March. But the way our cases are coming down, the demand won't quite be as high. It would be more useful to have a bigger supply right now. I also know that Eli Lilly is trying to get all of their data complete on their new monoclonal antibody, which should be effective for Omicron. It's bebtelovimab. Not sure I'm saying that right, but they're working to complete their emergency use authorization application and get that authorized through the FDA. So I think there's other monoclonal antibodies and other therapeutics on the horizon, but they just might not get here in time for before we really come off of this surge of Omicron.
Can I add on to that? Do we know about Paxlovid, the likely availability of Paxlovid versus since the monoclonal is not available?
We've heard similarly that they're going to increase the supplies of that considerably in the next month or two. But again, demand will be falling off. However, it would still be useful to have that as long as there's circulation and there's an oral treatment available. I think the increased supply of that will be very welcome. And so we'll be looking forward to that. I haven't been given estimates of numbers of treatment courses though that we could expect in February or March.
Thank you.
Great. And our next question is from Dr. Rohak. With the federal push for home testing kits, will that impact future DHHS stats on positive cases?
Yeah, we think it will. And, this is something that it's not just Texas facing, but every state across the country and CDC, for our national statistics right now. What we really, it's nice to have case counts of exactly how many people have COVID-19 so we can figure out, positivity rates and things, but really what we want to know are trends. Are we seeing outbreaks of COVID-19? And for now, the amount of testing that is going on in the clinical setting and outpatient or inpatient clinical setting is sufficient. We've been over the last few weeks, 150 to 200,000 PCR tests per day being done across Texas. And that's in addition to all the antigen testing that's being done across Texas and reported to us as well. And so we've got plenty of testing to be aware of trends that are going on in communities across Texas. As the market share kind of shifts, if we see like it all going to home testing, then there are ways that we can increase surveillance of what's going on in the home testing world as well. But for now, it's not necessary. It's a less valid way for us to get these results. And the results from home testing with our current surveillance definitions don't meet either probable or confirmed case criteria. And so we haven't prioritized those for now, but it's something that we're definitely keeping on our radar and coming up with contingency plans in case we need those reported to us.
And I would add to what Dr. Shuford was saying, as far as the home test, my biggest concern there really, because what Dr. Shuford was saying, through the reports that we have of molecular tests from laboratories, we've got really a pretty robust sample and a very more than adequate sampling, if you will, ability to test that way to see what the trends are in a very accurate way. My biggest concern with home tests is when somebody does the home test, even presuming they do it exactly right, and they get an answer, either positive or negative, do they really know what to do with that? Now, presumably, if they're positive, they say to themselves, man, I got COVID, and I'm going to isolate, and I'm going to, ideally go figure out what those isolation recommendations are. If they're negative and symptomatic, we all know that, if it was up to us, we'd be getting another test, getting a molecular test, a PCR test to see if that was a false negative in a symptomatic patient. That's not going to happen with home testing. Moreover, even if they're asymptomatic and they test negative, do they understand that that's today? Right now you're negative, and someday maybe you'll contract it and you won't be. So I have a lot of skepticism about the home testing. I think it's one of those things that kind of had to be done in order to give the public a sense of confidence and control. And I think that there's going to be lots of instances in which people use it correctly. But I worry again, will there be a resource, or do people know that they should seek a resource to help them discern how to act, what actions to take or not take, given a particular result?
Thank you so much. We've had several questions come in from Dr. Holland, from Dr. Vijayaswarapu, and from Dr. Villarreal, all related really to a booster schedule and the necessity or the recommendation to do a booster every 6 months. Would you care to speak on whether you think that that will continue into the future?
Dr. Schufer.
So I think some of it's going to depend on the durability of the antibody response after booster doses, which we're just now trying to figure out. And so that's one. To the effectiveness of further booster doses, especially using the older formulation of a vaccine. And so, thankfully, Israel has already gone there, and a few other countries where they can generate some data for us to really see how effective that fourth booster dose is, and if like a 6-month schedule might be necessary. But it's also going to depend on just the activity of COVID-19, how it circulates, and what sort of variants emerge. We know that variants are going to emerge, and that if it's significant enough that previous immunity does not protect against the new variants, then these booster doses at some sort of intervals might be necessary, be it a single component vaccine or a multivalent vaccine. And the vaccine companies are already kind of working on this. And so Pfizer is already developing an Omicron booster, Moderna as well. They've done a multivalent booster. And so that includes Omicron. And so it'll be interesting to see kind of how those figure into this schedule as well. But all of that to say, it hasn't been established yet, and some of it will just depend on the upcoming data that will be coming out of these different countries that have enacted it, and the what we see with the changing of the virus.
And if I could add, it's kind of a little bit of a tangent, I guess, on what we're talking about here. Going back to thinking about the work that Dr. Hotez has done in getting vaccines out to other countries other than the United States, that to me is where the biggest risk is. And we should now see it as being in our best interest, in the best interest of every highly developed country in the world, to get as much of the rest of the world vaccinated as possible. Because again, and Dr. Hotez may correct me, but I've been told that when you get the COVID infection, the virus replicates 1 trillion times in a given individual. And every time it does, there's going to be some variation. Most of those variations are less successful and don't propagate. But if you have hundreds of thousands or millions of people getting infected and having them generating those new variants, that's where it comes from. After all, that is exactly where Omicron came from. It came, if you will, from over the horizon. And it was very clear that even when it was recognized and early on, and it spread so fast, people were talking about, well, is it here yet? Is it here yet? Well, yeah, it was. It was here already in spades, in the sense that when the city of Houston did some testing of their wastewater streams, they found Omicron in I believe it was 9 out of 38 wastewater plants in the Houston system within a week or so of any of us knowing that really Omicron was here. So we should be very supportive of efforts to immunize the rest of the world, and likewise do what we can here to decrease the circulation of the virus throughout our communities. And that's back to booster, booster, booster.
Thank you so much to all of our panelists, Dr. Murphey, Dr. Shuford, and Dr. Hellerstedt. This is going to be our last question. We have just a few more minutes, and we're going to take a question from Dr. Turk. What is your opinion on whether the Omicron variant is setting the stage for a transition to endemic COVID-19? And I'll piggyback on that with looking forward, what do you think living with COVID as part of our everyday lives looks like in the future?
I think what we need to do is be prepared to do something different every time new information emerges. The virus's ability to have variants emerge is going to continue. I've heard it said that there's kind of a general principle in virology and its interactions with human beings. The virus doesn't want to kill you. The virus wants to reproduce. And so over time, things tend to become maybe more communicable, but less intrinsically virulent and causing more serious disease. Is that going to happen? Are we at a point where that's really something we can rely on? If somebody knows better, please let me know. But personally, I think we would want to hold all of our sense of that in abeyance. until we really see what happens. And that's a difficult message to get across, because again, as I said, everybody's sick of the pandemic. Everybody wants it to go away, but I think it would be a mistake to make assumptions about what the future holds.
Very well. Thank you all very much. Dr. Murphy, Dr. Hellerstedt, and Dr. Shuford. An excellent interactive presentation. I'm sure we could continue with more and more questions for quite some time,